All right, so we're moving into our panel session, which will be later facilitated by Kenneth and Michaela together. I'm having the great honor to introduce our three panelists joining us today in the country and outside the country. So first of all, we have Andrew Chung, who is the Executive Director at Fook Mental Health Association. He has worked in the nonprofit sector for nearly 20 years, most of which have been in healthcare and community service organizations. Prior to Fook, Andrew served as the Director of Philanthropy at Cambridge Foundation, leading the organization's major gifts strategy, the Recovery College portfolio, and community engagement and EDI initiatives as part of the hospital's $500 million comprehensive research capital campaign. Andrew formerly served as board secretary for the Asian Canadian AIDS Services, Communications and Policy Advisors at the Consortium of Agencies Serving Immigrant Professionals. Born and raised in Toronto, Andrew holds a Master of Business Administration and Master of Science in Healthcare Policy and Research from Cornell University and Weill Cornell Medicine, respectively. He completed his undergrad degrees at Toronto Metropolitan University. Our second panelist is Lucy Costa, who is the Deputy Executive Director at the Empowerment Council, an organization promoting the voice and human right of mental health clients. She has worked within the service user psychiatric disabilities community for over 2 decades, both at the grassroots level and in mainstream initiatives. She has produced educational curricula for many stakeholders and has spoken extensively on the need for critical thinking and ethical advocacy for service users, both in psychiatric medicine and law. She has written a number of articles, blogs, and is co-editor of Madness, Violence, and Power, a critical collection published by UFT Press 2019, as well as a special edition of the Journal of Ethics and Mental Health published also in 2019. And last but not least, we have heard from Dennis Kussin, who founded and directed the community mental health program at Toronto Western Hospital for over 20 years ago, and Dr. Kussin has recently retired. So I'll turn to Kenneth and Michaela to facilitate the panel.
Okay, so good morning, everyone. You've already heard from Michaela. My name is Kenneth Fung. I'm a staff psychiatrist working out of Toronto Western Hospital. And I'm the current director of global mental health. So it's my pleasure to be co-hosting this panel discussion with Michaela, whom you just heard of. So I think that what we would like to do, even though you heard like the really formal introduction of each person, maybe we'll ask each panelist to just speak a little bit for maybe 3 to 5 minutes or something like that, where you can kind of introduce yourself from your own words, and particularly highlighting your own experience in the field and your own passion for EDI, your own stance, and maybe what's inspired you to join us today. So maybe we'll start with that. Michaela and I have prepared also a set of questions. So we'll also take turns asking questions, and we'll invite any of the panelists to answer. But we thought maybe we can ask each panelist just to speak for at least as an opening, your own opening remark for 3 to 5 minutes. So maybe in the same order, I would just ask Andrew Chung to go first, perhaps.
Sure. Thank you so much, Michaela, Kenneth. Nice to see everyone. Can everyone hear me okay? Yeah? Okay. So I guess I should start by saying that, you know, I don't consider myself to be any sort of EDI expert. I think it's so vast and broad that I hesitate to say that I am. But I think my strong interest and longstanding commitment to it in my professional personal life has really stemmed from being an advocate for a mother who has schizophrenia. She was oftentimes found at the intersection of the criminal justice system and mental health care because of what I believe was the system's inadequate know-how and resources to care for someone like her. And she's an immigrant woman from Korea who bore a cultural identity that was shaped by the psychological shock of immigration in some cases in her own personal family life. And then here, having experienced a set of racism that's also been interwoven with misogyny while settling here in Canada. So, being a family advocate for her as she kind of went through the revolving door of the healthcare system and more specifically psychiatric care, I learned a lot about my family's sort of roots, where we come from, what it means to be a Korean Canadian, and then from there, how in my identity forming years, understanding who I am as a queer Korean Canadian, and then to layer on top of that is also, in a more like religious context, shaped by Korean cultural values that have really sprouted with immigrants from Korea who have shaped community here in Canada. So, that was really sort of the precursor to, I think, my strong interest in working in the nonprofit sector, and then two, in areas that are focused really on racial justice and EDI. So most recently, as Meng Chuan mentioned, I worked at CAMH Foundation and was actually a part of, co-chaired the EDI committee there, and learned a lot about what EDI looks like in the context of philanthropy, and that relationship between healthcare and hospitals. And it can be beautiful because of the research that it can fund and the clinical care it can help build capacity for. And it's also, philanthropy is also deeply problematic in its connection to colonization and extraction from other communities. So that was definitely a learning. The EDI committee actually recommended that the foundation put a pause on EDI work until it could figure out how to empower the community to operate outside of a racist construct. And that's sort of mind-blowing and really deep in a sense. But our CEO and board were very, very supportive of the decision, and really took that feedback to heart, to really understand how to engage staff, donors and volunteers and hospital in ways that really deconstructed the idea of structural racism within the walls of the institution. I also sat on the Diversity and Inclusion Coalition for the Department of Population Health Sciences at Weill Cornell Medicine during my time as a graduate student, representing the Weill Cornell graduate programs in medical sciences. There I learned about an opportunity to be considered for a fellowship where I was then recognized as a Dr. Lorna Breed Healthcare Legacy Fellow at Weill Cornell, where I developed a spotlight series on mental health and began with a conversation how organizations can support the mental health of Black employees. It's a discussion that is still largely missing from the curriculum, and really just scrape the surface of the greater need to ensure we center the experiences of racialized people and their many intersecting identities as it relates to mental health, as patients, advocates, or professionals within the industry. And so, now being the ED at Hong Fook, the Asian diaspora in Canada is very complex. We're not a monolith. We come with different perspectives, different, cultural nuances, and we're somehow trying to figure out what it means to support one another as disparate communities, but with underpinned by a common thread of sameness in our experiences here in Canada. So I consider myself to be extremely fortunate to be in this role, and really look forward to seeing how Hong Fook and other organizations can continue to partner with great people who are here today. Maybe I'll stop there.
Thank you, Andrew, and thank you for sharing. And I think, as we can just hear, Andrew, you're bringing both like a personal as well as systemic and structural discussion of some of these issues and really highlighting intersectionality in so many different ways. And we can even contrast like the official Ming-Chuan's introduction and your own introduction of yourself. We're reminded of like the very human dimension and what Michaela mentioned, that we have all these constructs of categories that lead to social injustice, but we reach to the humans behind all these labels. Then we have a further deeper understanding and how do we shape healthcare to really address those needs. So I wonder now if we can invite the next Lucy to similarly give like your own opening remarks and your own passion for EDI.
Thanks, Kenneth. And I just want to start by saying it's the month of June, and I wanted to wish everybody a happy Pride Month, specifically because it feels centrally important now with all of the increased transphobia, refusing to raise flags, pride flags at Catholic schools, and all the other kinds of microaggressions. It feels really important to acknowledge that. So some of you may be aware that on Queen Street East, there's the Queen Street Viaduct, which is the bridge that runs over the John River. And on that bridge, there's an art installation. And you may or may have never noticed, but there's some words that are on that installation that say, "This river I step in is not the river I stand in." And so I was looking that up and noticed that that sentence has to do with, originates with a Greek philosopher named Heraclitus, which is an expression for the metaphor that everything is in flux, and that because as the water and life within the river are constantly changing, even the river appears to be the same. It's impossible to step into the same river twice. And I thought about that for today because often this work for me, as somebody who's been doing this work for about 30 years in the disability and psychiatric disability community, feels like I'm revisiting the same river all the time, and that nothing's changing. But of course, things do change. And one of my things to do is like to try to pay attention to the small incremental changes that offer opportunities. And so I want to thank the organizers for Advocacy Day and all the social justice work that's happened, particularly in the last 10 years, because I want to acknowledge that that is some change that has happened. I am also not an expert in EDI, and quite frankly, more of a critic of it, as someone who's been looking at the way in which psychiatric service users have been involved, participating, and included over a long period of time. Really, I think the inclusion discussions began with the onset in 2010 of the Excellent Care for All Act, which proliferated a bunch of things. At the LIN level, there was a whole bunch of work and toolkits that were built to sort of help community level agencies engage patients and service users. But really the history of like psychiatric patients and service users trying to be included and get a seat at the table is much longer than that. From a governmental policy perspective, that started in 1988 with efforts to get into the Graham Report, which was a mental health government directive. So this work has been happening for a long time. More recently, I think what I'm passionate about and interested in and kind of want to flag as potential future points of discussion are three things. One is the role of pedagogy and curriculum as part and parcel of a process of EDI discussions, or whatever we want to call them. Because I think where we're at now does have to do very much with pedagogy and curriculum, and less with identity politics and representation, although that plays a role. We can definitely see in places like the United States where pedagogy and curriculum like critical race theory is being resisted and even taken to court in particular instances. And when we talk about inclusion, I think it's really great to hear about the different examples. I really enjoyed Nassim and Gary's presentation earlier. But I think one of the things that I've seen in the last, 10 years or so is a depoliticization of the way in which people are included. And so part of that, I think, needs to be challenged vis-a-vis the issue of engagement and less inclusion. And so engagement means engaging with the actual work, scholarship, cultural reproduction, art of service users themselves, and finding a way to incorporate that as a proper curriculum pedagogy, but as a meta curriculum and part of the other conversations that happen around intersectionality. The second point I just wanted to make has to do with the politics of labor and how service users are included within the dimension of work that's happening within the mental health sector, broadly speaking. And this merits a bit of reflection because the way in which service users and patients have been used as part and parcel of the labor of the mental health industry has a complicated and sometimes difficult past, because patients used to be used for labor, unpaid labor, and sheltered workshops and all this kind of thing. And that has changed, and we have more attention to that. But I think there are certain aspects that I would argue about the way in which there's a scattered economy of labor that is happening by utilizing patients in various roles, providing them an honorarium or providing them precarious work, that I think merits some reflection as asking the question, what is this, and what is happening with the scattered economy of labor that's being infused into the system by psychiatric patients. And there's a saying in the LGBT community called pinkwashing. I don't know if anybody's familiar with the phrase pinkwashing, but pinkwashing is basically the phenomena of corporate and big brands jumping on board onto queer politics and using that as a means to highlight their allyship. I think there's a similar phenomena that's happening in mental health, in the mental health sector, that I would call peer washing or patient washing, where there's a particular kind of allyship that's happening sort of with the notion of including patients or giving them like spots of work or whatever, but not really joining in the more larger political work that needs to happen, with looking more deeply at the curriculum, as I said, and also looking at capacity building with service users. People don't need to be consulted time and time again about what it feels like to sit on a waiting list to get housing. I think some capacity building that would be useful in the future in the work that we're doing together is to start to create opportunities to teach people to understand how they are agents or not agents in the systems that are affecting their lives. I think that would be useful. And then my final point is just about the need to look more deeply into the ethics of research and the use of patients in research, because this is a mandated phenomenon now with like large funding bodies like CIHR or SHRC or wherever, and that's a good thing. However, I think there's some pretty unethical things that are happening with the way in which, again, patients get plunked into research projects that serve a particular means to an end and not necessarily always in the interest of patients themselves. So my 5 minutes is way up, so I'll stop there.
Okay, thank you so very much, Lucy. Always wonderful to hear from you, highlighting many important critical issues about pedagogy, about true engagement versus kind of tokenistic inclusion or something, capacity building, ethical consideration, all of those are crucial issues. And I just also want to highlight both you and Andrew start off by saying you're not EDI experts, both of you, which is such an amazing thing to have this panel starting off, allowing us to critically reflect on, EDI terms, what it means to be expert, querying these kinds of terms. both kind of the role of who's expert, who has expertise, what does that really mean? And even EDI itself, what are the limitations of that framework? So that's really amazing. I guess we'll invite next. He is not only the mentor for Michaela, he's my mentor as well. And before Michaela was a resident, I was a resident. And so I still consider Dennis kind of my mentor, and he's the proverbial classical wise teacher. So invite Dennis for your thoughts.
Sure. Do I need to press anything to get? I'm fine like this.
You're fine. You don't need to press anything.
Okay. One quick comment that I had, what about Michaela's residency, and Ken's critical one. When he was my resident at one point, we had established a Portuguese mental health clinic at Toronto Western, and it was Jose Silveira that was a fellow, I think, or a resident right around when Ken was anyways. And there was a lot of, and there was staffing of it and all this kind of stuff. And one day Ken was in supervision with me and he says, "What's all this stuff about the Portuguese?" Which was not being against the Portuguese, but saying, "That's all I hear. What about the Asian community?" And I remember well my comment looking at Ken and saying, "Well, what about the Asian community?" And that was the beginning of kind of AIM. That then Ken took that on as his issue. We used the Portuguese experience in a lot of ways in terms of doing needs surveys, going to government for staffing and all that, and it all began. So one important thing is for all of us, when we say we're not expert in this or that, we in fact are by the length of time we've been interested in the issue. All the ones of you that I know well have been interested from day one in terms of becoming psychiatrists and being a psychiatrist. So this is not something that people wake up to one day and say, "I think I'll do this." And all of us in my own was, I grew up in an immigrant family. My parents were Jews from Poland. They were also strong socialists, and all those things clearly influenced my own thinking in these areas. I'll do a quick overview of my kind of curriculum vitae, but it'll have to be very quick because I spent 50 years as a psychiatrist in university psychiatric departments with all the politics and everything else involved. My interests have always been one, education, and I was a postgrad director at one point in the late 80s, and have always been an active teacher and supervisor, and tried to bring an integrative, large picture approach to clinical work. And when I look back on it, I can see that advocacy, in my particular framework of it, has always been a part of my work as a psychiatrist. Okay, I'll focus on the last thing I've done because it's in the last 20 years or so prior to my finally retiring. And I'm very envious of the bamboo behind Ken's picture for my backyard, which is a Japanese attempt at a garden, is my next step. But what we started at Toronto Western, well, first of all, let me say my interest has been advocacy in big picture. And I think we need to look at what has happened to the psychiatric community, that is patients, and where we have failed them, and look more carefully in our own backyard as well. So I have, like I said, 50 years experience of seeing different trends happen. There were 5,000 larger numbers of patients in mental hospitals when I first went into psychiatry, and they were being pitched out fairly aggressively without much in the way of resources for them. And we did that to psychiatric patients. John Talbot, who wrote a book, and was a lovely man, called it The National Tragedy. And we are still seeing the results of that. People who can't function easily outside because of symptoms or whatever are now in jails or are now in inadequate boarding houses or shelters or all this kind of stuff, or on the street. But it came from that. And we, as an academic psychiatry, supported that at the time. And we have quite a history of, as in academic psychiatry, of supporting measures that disenfranchise psychiatric patients from receiving care. That's the way it is. That was one example. I remember going through it saying, oh my God, there were community psychiatrists then, I'm talking early 70s, late 60s, but early 70s anyways. And you could, by nature, I'm cynical, but you could spot them a mile away. They would all be carrying attaché cases. They'd be heading for meetings. They didn't see many patients. And their main concern was who's going to be at the table, would always be the question, and the politics of it and all of that. But nobody was providing service to these people. Psychiatry, also academic psychiatry, is always look for somebody else to take on this role. They haven't read the dictionary, which is the definition of a psychiatrist is a physician who diagnoses and treats the mentally ill or mental illness. That's what it is. And so I've just watched this shifting. Initially, it was going to be the community that somehow would heal them when they were out of the hospital. That didn't work. Then it became various kind of community clinics, underfunded. That didn't work. The latest iteration of this kind of stuff, which is, in my view, and I've said it, fairly foolish, is that somehow family practice will take over this role. Well, my son, who's 30, and his partner, who's same age and fairly healthy, and they live in Kingston, can't find a GP. They're on waiting lists and all that. So there are no GPs out there, and they're not trained to do this. You can do it, and I have done it for 15 happy years at a community health clinic in Parkdale, but that's with a different kind of model. So I'm saying one of my concerns is advocacy for this patient population in our own settings. There is considerable ambivalence about the issue of providing care at the university level. What is its policy for providing care? All of those. So those are my kind of interests. We established a clinic, Ken is a big part of it, using population health as a model, and we kept it going for 20 years. The politics of it was very interesting, and we can maybe discuss a little bit of that later in terms of what you have to go through to do it. But nonetheless, we kept it going for that period of time, and that's another interest. I'll stop there.
Oh, okay. Thank you so much. As you alluded to, there's so much more to be told, and we do have more questions to flesh out some of these issues. As you alluded to, there's the importance of looking at system politics, but also getting back to the roots of like the dictionary, or who we are and what we stand for and what we care about, right? And so that's the question that we're.
And the big issue is the one I would call ownership.
Ownership. Yeah.
Which is who owns responsibility for the problem? The problem is clear. People can't get access to care.
That's
Who's
an
responsible for doing something about it?
Yes, yes, exactly. So that's a good segue to our next segment. So perhaps I would turn things over to Michaela, and we have some questions to address to ask the panel.
So we do have a specific list of questions, but I want to actually go back to Jacqueline Vincent's question in the chat. I'll read it out loud because I think it's a really important one, and maybe we can start there. So Jacqueline was saying, would love to hear your thoughts on how you maintain hope and optimism and momentum in the face of rising political conservatism in many places, systemic indifference, slow pace of change, etc. Asking for us as advocates and also for us supporting others. I've had a number of patients who express a sense of demoralization and hopelessness with the state of the world. So grateful for the work and sharing what you do. So I'm wondering, maybe we can start go in the same order. So start Andrew, Lucy, and then Dennis. Thinking, what are your thoughts in terms of how to maintain hope and optimism in the face of rising political conservatism?
Oof, that is a big, tough question. I think I vacillate day to day, depending on what I hear on the news or what I'm hearing from different communities that I'm a part of. But you know, and this is going to sound, not evidence-based or anything. But for me, how do I maintain hope and optimism? I think I firmly hold on to my values. And I had to go through this value structure exercise in a course a little while back, and it really made me understand who I am and what drives me in my own purpose. And what I realized was that in the larger collective of the 49 students that we had in the program, that they were all very similar, that we could all be interconnected. And it really gave me such hope that even those who may seemingly sit a little bit differently on the political spectrum, with a bit of empathy, could be open to hearing me, and that maybe there's hope for change. I also, surround myself with people who will affirm me and what I believe in, and really wrap myself that they're my safety, right? My squad. And it's really important for me to be around those people because they give me strength, and I draw a lot of strength from them. I will say, I'll be honest, like I don't always feel hope or optimism. Like I think about like climate change and think like, oh my gosh, like already the psychological impact on young children, and their the increase in anxiety and worry over the world that's changing, or my trans friends who are losing their people from their communities to hate crimes. It's incredibly worrisome, and I think that in some sense we have to know what that feels like, or at least I do, because it also keeps me grounded in like what's at risk of being lost if we don't do something. And so I think it's a bit of both for me, and I think I welcome it in a sense that I think it keeps me grounded. I hope that helps.
Thank you. Lucy.
Yeah, I haven't even begun to start reading anything about AI and the complications of AI with what's happening with the rest of the things going on in the world. I think one of the mentors that I have says to me that it's really important to, with all the suffering that's going on in the world, is to remember to focus on what you can do yourself on a small scale, and trust that is important and that does something. So that is what I try to do myself personally. I try to stay focused on what are the actions and practices and habits that I can foster that are going to be helpful for myself and others. I do feel hopeful about the stuff that happens like in sort of subcultures of care and resistance, that there are still people organizing, even though there's no advocacy funding, even though, well, you gave an example, Michaela, of the action that you did as well. Like people are still speaking, articulating, resisting, protesting to the best of our ability, and finding ways to support ourselves, like through those mechanisms. So I find that hopeful. I find the circles of care that people do that don't get any kind of recognition, I find that hopeful. On a practical level, I do feel a bit of a challenge in terms of, like, since the pandemic, feeling disconnected from people who use services. I was at the CAMH yesterday, and it's still quite, people aren't back at work, and so it's still quite dead, and I don't see patients meandering about it like I used to. And so I'm trying to figure out ways to make spaces more accessible, because people lost a lot of services when the pandemic hit. Like community agencies were shut down, hours were diminished, and so I'm thinking about ways in which to create more spaces for people to reconnect in person, because there's been so much isolation.
Thank you. And Dr. Kussin.
Hopelessness about the world, I kind of try to leave outside my work, which is you can do what you can do. And I've also lived long enough that I can kind of say, hey, I remember being 17 and all of us were convinced that we were going to die in a nuclear war. And that was all of our adolescence at the time, and we forget that. So it's, you know, issues have always been there, and issues from between the right and the left have always been there. The fortunate thing that we have is if we're clinically involved, one way or another, I've always found my hope and in my work with my patients. It's a mutual endeavor, and whatever I give, I get back, and the two of us kind of against the forces that are leading to whatever, and just love between us is where the hope is. So that's the basis of the therapeutic relationship, whatever else we call it, and caring for each other and really trying to change things with somebody and working like as hard as you can to do it. The hope is there. There's also hope in terms of you and your colleagues. So I've often found surrounding yourself by a group of people who are trying to do what you're trying to do, and tremendous hope in teaching. I've always found in that, yes, I lose a certain number of students over time in terms of you get them in the beginning and then you see what the system does to them over time. But overall, look at you guys, the ones anyways I've been involved with, and there's also hope there. When we discuss kind of psychiatry, the other thing is I tried, that's part of my personality, but I try to access, rather than an attitude of hopelessness, but a feeling of outrage and anger at what's going on. And just raging about it doesn't help at all. So you got to find a way to be politically active, but with an edge to it. You've got to channel that kind of anger about what's happening and saying, I'm going to do something about it, but it's got to be effective. It can't just be insulting people or raging. And there are ways of doing it, and you'll find at the end of your professional life, you'll have a number of scars and wounds on your back where people have got after you, but you can do a lot. And so overall, I've always said with psychiatry generally, yeah, there's a hopelessness about our lack of research breakthroughs and a lot of other things. But somebody wrote the title of a book, and I've always liked the title. He said, the situation is hopeless. but not serious. And what he meant was, if you look at big picture stuff and you can feel some hopelessness, but what's not serious is that you can always do something. And there's a lot we can do at a clinical level, at a systems level, but it requires putting yourself out there into the fight and developing some skills at that.
Thank you so much. I mean, I think the answers spanned everything from the individual patient care all the way up to those big macro, advocacy, systemic things. And I know for me, the way that I keep hope is by doing both clinical care and also, just the advocacy that was talked about today, because I think without addressing those root causes, I don't know if I could continue to do the clinical care and feel that things were moving onward. So I really appreciated that question and the answers. Another question that we had is, if you could cause radical change in the system, what would that be? And you can take that in many different directions. I mean, you can think about access to care, you can think about broader systemic things. If you were able to create change, or if you are creating change in some ways, what would that be? And happy for anybody to answer. It doesn't have to be in the strict order. I don't know if anybody else feels ready to answer that.
This is like the magic question, but for advocates. If you can cause and disrupt radical change, what would you focus on?
This is a bit of a difficult question because it takes my brain into thinking about like radical politics proper. But I do want to point out that with the incident of George Floyd, there was a bit of radical change that happened fairly quickly. And so examining like what the motivation, like understanding more deeply like how that some of those changes happened in the span of time that they happened, like suddenly there were like jobs, positions, initiatives, all these things that happened fairly quickly, as opposed to the slower pace that all of our advocacy takes, I think merits like a bit of reflection. So maybe it's not so much about what is the radical, but what is the motivation? Like how do we stay motivated and get ourselves motivated to make change quickly?
Well, one issue of radical change that I would advocate for, and I'm doing it in the context of not fantasy, discovering the cure for schizophrenia or all that kind of stuff, but with where we are right now, the big issue remains access to care. That to me is the biggest issue ethically facing us. And when I talked before of ownership, I think we need to own it. Yes, the government has to own a piece of it. And yes, the university has to own a piece of it. And yes, the general hospitals have to own a piece of it. And they've all backed away from it. But in my experience over those years of running a population health program, and that's what the literature tends to show, one of the few ways of improving access to care is through a population health approach to it. It's doable. So that I know, because we did it. We did it for about 20 years, and I'm not just blowing my horn or kind of our horn and saying, but nonetheless, we did it. And so I would propose and hope the radical change would be that a group of you guys get together and design a program that would, a population health-based program, for starters, to the Central Lynn or Toronto. Don't forget all of the university hospitals are in that area. We are the ones who are providing or not providing the care. So if we meet with the ministry, and if we meet with partners in the community, and as a university, we design a program that would allow access to care for anybody living in that area, and how they would get it and where they would go. And then we go to government and say, we need funding to be able to do this, which is what we did and got it. And then make it a research project, and to see if you can do it, and what are the blocks to it, and how it would work, and all those things. Publish it, show that you can deliver a mental health care system for a large city with a particular model and structure. I think we're there. I just think the will has not been there. It would mean being politically active at the university, which has yet to define its role in access to care. The fact that it owns most of the psychiatrists in that area and all of the hospitals in that area. It will involve government, which was doing something with the LHINs, but is now doing much less. It would involve community partners to hopefully break down this divide between hospital and community, and whoever else, but to design it, in fact, as a research project, get some commitment for funding in terms of what you would need, and see if you can do it. Nobody's done it well and published it that I know of. Although a lot of programs in Scandinavia are doing it, but so that's a task for you guys at the university. Dig in, guilt them. Guilt works wonderful at getting things done, and get it done. Start with, what is the university policy about access to care? What is the general hospital's role in access to care? All that's been distorted. You'll find the rules are there, but it's being ignored. So that would be my wish. There you go.
Andrew, anything you would add?
Yeah, I was thinking about a few different things. I was like, oh, universalized talk therapy, or increased modes of interoperability between hospitals and community-based organizations. But I think maybe from a funding perspective, it would be great if we could have, if community-based organizations could receive greater unrestricted funding, which seems to be still like a very novel idea. And I say this because I think a lot of nonprofit organizations, community-based organizations, are seen as gems into access into communities where large organizations have trouble reaching into. And so we're asked to partner, we're asked to collaborate, we're asked to do a bunch of things without really recognition of what it costs the organization to get that done. And then there are all these restrictions around, the funding. And when we look at ethno-specific organizations, like Hong Fook as an example, we don't have access to the same kind of philanthropic dollars that hospitals do. And these are, it's like older white money that's lived in Toronto and Canada for a very long time. And I think intrinsic in our philanthropy and how we've done things in healthcare has been actually very racist. So what I would hope to have is the opportunity to say, if philanthropists are going to fund research and other areas of care with these with bigger hospitals, that perhaps there is a responsibility and onus on both philanthropists and hospitals to recognize that none of this work can be done without community partners. And therefore, we need to be at the table and be beneficiaries of the funding that they seek in order for justice to be actually served and distributed equitably among racialized communities that really are impacted the most when we look at health inequities. So I think that would be my one wish around radical change in the system.
Thank you so much. And I mean, I think what has been really inspiring and special about today is that we're talking about universities and the hospital, but we're also talking about community. And I think you've offered a very strong call on many fronts, right, about the importance of community-based services that are responsive to community needs. So we have probably just about 5 minutes before we need to, I'll hand it back over to Meng-Xuan and to Lisa, but just wanted to end with one last question, which is, you know, are there any last things that you would like to share, specifically calls for us within the hospital system or for us within the university? We're all the U of T Department of Psychiatry. Are there any last words that we should consider as we continue to do equity work as a university department? So I will just hand that over to you, and just if you could keep the comments pretty brief, just because we have max 5 minutes and then we need to start wrapping up.
My one comment at the hospital level would be for all of you to learn the politics and also learn what's already there in terms of rules as to how money is supposed to be spent rather, because the rules are there. They're just sidestepped a lot in terms of quality of care and community care. So learn the politics of the situation. Don't be naive.
Got it. Thank you. Andrew or Lucy?
I'm just putting in the chat. I agree with that last point about politics, and I'm just going to put in the chat like some areas that, if we go back to patient inclusion, which is what I was talking about, and patient engagement, just where I think patient engagement exercises need to move from the singular to the collective and take up the issues that I'm just going to put in the chat.
Thank you. And Andrew?
I think I'll start by saying my managerial finance professor said, a measure of our character is not defined by how we treat the people that we love, but how we treat the people that we don't love. And you know, I say that because I think when I think about my mom in the psychiatric mental health care system, I thought about, you know, if this doctor or if this clinician had the person that they love the most in my mom's shoes, how would this person have been treated differently? And I think therefore there is proximity and power in being immersed in community with the people that you don't hang out with, that you are not used to surrounding yourself with, and imagining and going into places where you are, that's not your usual social location. I think that could be a very transformative experience for clinicians to remember the people who need our help the most.
Thank you. And maybe I can hand it over to you, Kenneth. I don't know if you have any last words or summary comments from the panel.
Well, I just want to thank the panelists, and I thought that this, I think I speak on behalf of all of us, that today has been so far an illuminating day, and looking at a lot of these issues, shining lights on a lot of these issues. I think the panels for me highlight a lot of what Michaela has also talked about too, with the same message, which is them versus divide, because oftentimes EDI issues, we talk about specific populations, and yet as a lot of you mentioned, Michaela, Andrew, a lot of you have mentioned that we do need to address these population issues, and we also need to break through these constructive labels that put people into different categories. If we can feel that, like Andrew was saying, like this person on the street could have been my mother, for example, and examining the values and interconnectedness, while allowing us to feel all these emotions, fueled by all these emotions that, Dennis and Lucy's talked about, from kind of hopelessness on one end, that was a question, to kind of moral outrage and anger, and how do we channel that to kind of the sadness and empathy. I think as a department of psychiatry, we are well versed to really look into both components of the humanity, the values, as well as the emotions, and how do we harness that, and finally to take more effective actions, and actions at different levels that we've highlighted in the micro and the macro level, a lot of which again is to break down these silos and to work together and have more investment in the community and more investment in the people to move forward in some kind of a direction. And I think that inspires a lot of us to keep going and not burning out, to feel that there's hope of movement. And even though the river looks the same, but it keeps changing. And who knows, you might discover more wonderful, beautiful fishes in it if you see it. And that we can be all together in that. And I wonder if I can turn things to Lisa and Ming Chuan to have this wrap up for today then.
Sure. Thank you so much, Kenneth and Michaela, for moderating the panel. Thanks to all of our excellent and inspiring panelists who are each in their own way very much sharing their expertise and also very deep personal thoughts about this work. I also want to thank the people who presented earlier in the day, and also our resident presenter, Maggie, for all of her inspiring work as well. And hopefully the revival of this Advocacy Day will continue to include learners and residents, cross-disciplinary people working in mental health, both in the community and at the university level. And, I think we all have a lot to bring back to our council, to our clinical settings, and to discuss based on today. I also want to thank Mr. Andrew Pakula and the Dr. Sophia Pakula Social Justice Fund for making this day possible. And I will now turn it over to Ming Chuan for some last words.
Thank you all also, and apologize if there's fire alarm happening. There's fire alarm test. But just some personal reflections on this. I think the hopefulness and the hopelessness are really coexisting in everything we do. And whenever there's hopelessness, there is hopefulness. That's what I believe, as always. And I think all the panelists and the speakers today actually shows us like how we can cultivate the hopefulness in spite of the hopelessness situation that's happening around us. And I think advocacy is so intrinsic actually to what we are given to do and what we are positioned to do as a service provider or people in a professional situation that provides some helping role to anyone who needs help and service. So I think cultivating that awareness of advocacy is really needs to be inspired by having access and to things like Advocacy Day and being involved in work that you do. And that reflects my personal journey in the past year, actually getting more involved and learning from the work that you all do. So thank you all very much for giving us a chance to listening to you, and hope that we have the chance to connect and work together more in the future.